Right, shall we start then? Good morning, everybody, and welcome to the SPCR Masterclass, making your research accessible to people living with hearing loss and the deaf community. Our speakers today are Dr. Etna Heffman, Paul Bateman, and John Turner. I would like to say that this is going to be recorded. As a result, we have turned off your cameras and your microphones. If anyone does have any questions they want to ask, if they would like to put them in the chat, we will ask them at the end of the presentation when we have 15 minutes. Alternatively, if you would actually like to ask the question yourself, we can unmute your microphone. So what I will do is I will pass over to Etna to begin the presentation. Thank you.
Thank you. I'm really pleased to be here today to talk about this topic. I'm currently doing a postdoctoral fellowship with the School for Primary Care Research about making primary care services accessible to adults with hearing loss. So it's important to also make your research accessible to them as well. And today I'll be joined by my colleague Paul, who has many years of experience as an audiologist, both in the NHS and outside of the NHS. He joined the Nottingham Biomedical Research Centre as a research audiologist, and in December he was awarded a PCAF. And I'll also be joined by John Turner, who is an expert by experience. He's the chief executive of a charity for carers and was awarded an MBE for his voluntary work. And he's contributed to various grant panels and steering committees and grant applications, including working with Diabetes UK, Comet in Liverpool, and the MyFoot programme in Leicester. Okay, so I wanted to talk about this topic because I believe hearing loss is very important, but it's often overlooked and misunderstood. Hearing loss is extremely common. It affects 1 in 4 adults in the UK, and in fact, as many as 1 in 3 will experience hearing difficulties in various everyday situations, such as noisy situations. So it's highly likely that some of your research participants will have hearing loss. And we know that awareness of hearing loss is quite poor amongst the general public and also amongst health professionals. And they are recognised as an underserved group in research. This not only affects the quality of the data we collect, it also has an impact on the participants. And what people have told me is when a study isn't accessible to them as someone who has hearing loss, it really knocks their confidence and gives them anxiety. So we need to address this. And the good news is, if you make your research accessible to people who have hearing loss, it often benefits other groups as well. A lot of it is about improving communication, and that tends to benefit everyone, not just people who have hearing loss. So I'm now going to hand over to Paul, who's going to talk to you for a few minutes about hearing loss and about how we assess this condition and manage this condition.
Hello, hopefully you can hear me okay. Great, so early on test worked okay, fantastic. So what I wanted to do is just give a little more of an overview really. I understand people who work in primary care are be very well aware of various ear conditions, probably have a lot of experience as well with managing these, particularly first line management. So I just wanted to give a bit of an overview of some of the anatomy behind hearing, the anatomy of the ear, and a little bit about hearing loss and a little bit about some of the tests we use to basically detect hearing loss. So firstly, just a quick overview of the ear, which is just an overview. Most people would know this. You've got the ear canal first. So the ear is made up of you've got the ear canal, you've got the outer ear, which we can all see, okay? You have the ear canal leading to where the middle ear space is. So you've got the eardrum, followed by the ossicles, the little bones that transmits the sound from the eardrum to the cochlea. So you've got the malleus, the stapes, and the incus and the stapes, sorry. And then you've got the cochlea, that snail-like structure. I'm not sure if you probably can't see my cursor on the screen there, but never mind. So you can see the cochlea, and the cochlea picks up the sound vibrations and converts that to electrical signals, which go up the 8th nerve to the brain, basically. So that's a very, very simple overview. One thing I would say to note is look how the cochlea is embedded in that bone, that the mastoid bone itself. That's quite important when it comes to some of the tests we use. Obviously, the location where the cochlea is, and the middle ear space is important too. That's where it should be air there, and often you can get some conductive conditions, which we'll talk about shortly, which can affect that. And also the eustachian tube, you can see leading up to that middle ear space, which helps equalize the pressure between the middle ear and the outside. To next slide, please, Edna. Yes. Okay, so types of hearing loss we've got. So common types of hearing loss, well, sensory neural hearing loss is the main one you tend to come across in terms of when it comes to age-related. So that's where the nerve of hearing, the cochlea itself, or beyond the cochlea, is in some ways affected or damaged. Age-related is the most common one. I just mentioned that, along with noise-induced. So with a lifetime of working in noisy situations, you can maybe expect to find noise-induced hearing loss. There may be genetic causes behind that, or injury to the cochlea itself or the nerve. Occasionally you get some tumours that can grow on the nerve itself, which can cause a sensory neural hearing loss. But the most common cause we see is presbyacusis, age-related hearing loss. Another approach, especially for young people, is conductive hearing loss. Is quite, and again, with kids in various communities, you'll find glue ear. I'm sure many people have come across that. So otitis media with effusion, mostly known as glue ear. Perforated eardrum can also cause a conductive hearing loss along with infections or malformation of the ear. So conductive is exactly the way it sounds. It's the conduction of sound is being impeded somehow. So it's often the middle ear. It could be the eardrum, the ossicles, or congestion within the middle ear space, stopping the sound from efficiently getting to the cochlea. A mixed hearing loss is a combination of conductive and sensory neural, so it can be any number of things combining the two conditions. So you could have an existing sensory hearing loss with age-related hearing loss, for instance, and be complicated by middle ear infection. Okay. And there's also functional hearing loss. This is where people report hearing loss or difficulty in hearing, but there's no observed clinical signs. Often referred to as non-organic hearing loss. It isn't as straightforward as people in the past thought, people faking hearing loss or malingering. It can cover a fair amount of conditions. But that's quite a lengthy topic, quite a big subject. Next slide, please. So how we test for hearing loss? Typically, we use the gold standard. The favorite is pure tone audiometry. It's very sensitive and specific to different types of hearing loss. Basically, the patient responds to a tone. They have some headphones on and they press the button when they hear a sound. We measure different frequencies and different levels of sound, and we literally record the quietest sound they can hear at a given frequency. Another test we have is tuning fork tests, which we don't use in our settings, in our typical clinical settings, but in primary care, it's still used quite a lot. It's where we use a tuning fork to determine whether someone can hear the sound in both ears equally, or whether it's louder here or when you press the tuning fork on the mastoid bone. It's a very, very useful test. It's still used quite a lot. There's also online tests, which we just want to mention. Is RNID and World Health Organization have their own online digit and noise tests for people to self-test, and it just gives you an idea whether or not someone's got indications of a hearing loss or not. You can do this on almost any PC or smartphone if you've got your own headphones. There are many, many other tests, and this is only just a quick overview. Far too many tests to go into just for an overview purpose. So next slide, please. This is just to give you an idea of what an audiogram looks like, but mostly it's where speech sounds tend to occur. So can you see the banana? People always refer to it as a speech banana, and it's great because it's coloured yellow. And you can see where the different speech in terms of sounds appear within that speech banana. So that's typical speech sort of levels. So like the low frequency sounds down to the left as you look at it. So down to 250 hertz, 500 hertz. That's the deeper low frequency sounds, right up to those high frequency sounds like the S's, TH, F sounds. Again, with age-related hearing loss, you tend to lose high frequency first. So you can imagine trying to make sense of some words, or it would be quite difficult if you can't quite catch all, someone's speaking to you, but you can't quite catch what they're saying. It's quite a common report. There's also some idea that like minimum hearing protection at 95 decibel, you can see in that scale on the left side, that's how loud the sound is. And you can see it needs particularly loud noises. You should be wearing ear protection. And we tend to tell people, please do. And we've also got, again, things like bird noises, high frequency, telephone ringing can be high frequency as well, but you can change those to be low frequency in some phones. But yeah, I just thought we'll present that slide to give you an idea of how some sounds are, where they are on in terms of a hearing scale. But that's also a similar chart to what we use to report hearing loss. So on the right scale, right hand side, you can see mild, moderate, severe, profound. And we tend to take an average around those frequencies. Next slide, please. It's okay. So just a very quick run through of management of hearing loss. Surgery is probably the most common in terms of the medical intervention side. So like for conductive hearing loss, you can treat glue ear with grommets, for instance. It's like a little perforation held open by a little tube, basically. The eardrum can be repaired, tympanoplasty. If there's a hole there and it's possible to repair, then surgery can be carried out. And there are other types of middle ear surgery as well, quite a complex set of middle ear surgery. But they're the most common ones there. For sensorineural hearing loss and for some conductive hearing losses, hearing aids are a major management, quite an important management. So you can aid one ear or both. And hearing aids come in different shapes and sizes. Most in NHS, we have the beyond the ear types. And again, privately, these can be purchased. In the ear, you can have beyond the ear types, depending on need and your own circumstances. Cochlear implants, that's when you tend to look at the more severe to profound hearing losses, where hearing aids stop being quite so effective. And this involves an implant surgically placed within the cochlea and a little device worn on the head. And it looks like a traditional hearing aid, which picks up the sound and transmits it to the electrode within the cochlea. Okay, and this fires off signals up to the brain as the cochlea would. Okay, and they're quite specialized pieces of equipment. Normally obviously involves surgery and involves quite a lot to set up. It's quite a process to get used to wearing. And we also have bone anchored hearing aids, which are more simplistic, little device that sits inside or presses on the mastoid bone and transmits sound to the cochlea. Not forgetting hearing therapy, which is hugely important. I think Etna's going to talk a bit more about this in a moment. So you've got hearing tactics, speech, lip reading, assisted devices, and access to work. So things that people can buy to help them go to work, basically, such as additional devices for using the phone, things to attach to hearing aids to allow hearing in meetings better. But again, it's us. Anybody communicating with people with hearing loss, it's good hearing tactics, facing people, making sure they know that you're speaking to them, and also allowing people to express how they want to be communicated with. So I think that's it for me. So I think that's the last of the slides. I'll pass back to Etna. That's okay.
Thank you, Paul.
Okay.
Yeah, so I'm going to give you a little bit more information about hearing loss and other hearing conditions, and then talk about how to make your research more accessible. So these are just some of the most challenging situations for people who have hearing loss, including people who have a mild hearing loss. So group conversations and conversations in background noise can be very difficult. So in terms of research, things like focus groups and workshops where there's a lot of background chatter going on, maybe different breakout groups are discussing things, that can be very challenging. Also conversations where you can't see the other person well, such as on the phone or where it's dimly lit, that makes lip reading very difficult. Also, for many people with hearing loss, lengthy or demanding conversations are tough. So they might be fine for a shorter session or at the start of the day. But if you're doing a full day workshop or a conference, they might get quite fatigued because listening is very effortful. Also, conversations with new people are tough. if you see a different researcher or a different clinician every time you go to an appointment, it's hard to get used to their voice. And even just traveling to take part in research or to go to a clinic is tough. If you're at the station waiting to hear an announcement, or you're in the waiting room waiting for your name to be called, if it's not flashed up on the screen, all of that is already making you a bit anxious before you've even started. So it's important to be aware of this. There are also various misconceptions about hearing loss that you need to be aware of. One is that hearing aids fix your hearing loss. And there's an idea that maybe if someone's wearing hearing aids, they don't need so many accommodations. But actually, although hearing aids are beneficial, there's evidence they do improve quality of life and listening. They don't completely fix your hearing. Especially if you're in the early stages and you're still acclimatizing to your hearing aids, or if you're in a noisy situation where your hearing aids are amplifying that background noise, you'll still have some difficulty. There's also an idea that it's just older adults who are affected, but really, even if you have younger adult participants, they could still have hearing loss, so just be aware of that. And there's a general idea that hearing loss is no big deal. And for some people, they manage it quite well. But for others, it can have a big impact on their mental well-being and their occupational functioning. And it's not just a hearing loss, it's also a social loss. It can make some people quite isolated or excluded. And it's a risk factor for various other health conditions, such as depression, loneliness, dementia, and falls. So it is important. I've been talking a lot about hearing loss, but I also want to tell you about the deaf community. So the deaf community are a cultural, social, and linguistic group. In the UK, there's roughly 87,000 members. So they're a lot smaller in comparison to people who have hearing loss, but they're still very important. They mainly use British Sign Language as their first language. And they have their own unique and rich culture, including their own customs, identity, and networks. And many members of the deaf community would not view being deaf as a disability or as a medical condition that needs to be cured or treated. It's a state of being. And they also may not view it as having a hearing loss, because many people are deaf since birth or since early life. So it's not the same as being an adult and losing your hearing in adulthood. It's not exactly a loss. What might be beneficial for the deaf community is more that society is accessible to them, that there's a greater availability of interpreters when they take part in research or visit clinics, and more resources available in sign language. And when we write about the deaf community, we tend to use an uppercase D to signify we're specifically referring to them. So this is just a quick snapshot. Obviously, it's hard to summarize a complex culture and a community in just one slide. So it's just a starting point for you to go and learn more about them. You should also be aware of some other hearing conditions. One that's quite common is tinnitus, which is perceiving a sound such as ringing or buzzing when there's no external source for that sound. And everyone experiences this sometimes, such as when you go to a concert, but some people have chronic tinnitus that affects them every day, and that's quite loud and really interferes with their functioning. Some people have hyperacusis, which is when everyday sounds are experienced as being extremely loud or painful or distressing. And these people don't have super hearing. It's more that their sensitivity or tolerance for sound is affected. I asked my participants what are the barriers that put them off from taking part in research as people who have hearing loss. And in addition to the lack of awareness of hearing loss, some of them also said there's a lack of empathy. People get quite impatient with people who have hearing loss. They get fed up of repeating things for them. So they kind of feel they're treated as a bit of a nuisance at sometimes. And also, there are still a lot of jokes about hearing loss or hearing aids. So it's still a stigmatized condition. Also, many people with hearing loss have had bad experiences in the health service and in research. A lot of people tell us that absolutely every single time they go to the hospital or to the GP, they have to remind them that I have hearing loss and remind them of what accommodations they need. So it gets quite tiring having to advocate for yourself all the time. They also want to know what are the benefits to research for them. Especially with the deaf community, they experience so many barriers to healthcare. They want to know if this is going to benefit their community. And if you do invite someone to take part in something like a focus group or coming to a session, if you don't explicitly mention what accommodations you're going to make, that can cause people to be very nervous and anxious and might just put them off taking part. I've listed some things here that you should avoid saying. Recently, I was at a conference and someone who wanted to ask a question said they weren't going to wait for the microphone to be passed around. They'd just shout out their question. That's no good for people who have hearing loss. They need you to use the microphone. Also, it's very common to get tired of repeating things and to just say, oh, never mind, it wasn't important. But you have to persevere and maybe just try rephrasing or even writing something down rather than giving up. You also hear sometimes that people with hearing loss, oh, they only hear what they want to hear, or they have selective hearing. But as we saw earlier from the speech banana, you genuinely hear some sounds more than others, or you might understand a deeper voice more than a high-pitched voice, so they genuinely have different kind of ability to perceive different sounds. You also hear a lot in meetings, how about we skip the break, or how about we carry on the discussion during the break? But listening is really tiring. So, it's important to keep the breaks. Another thing people say is, maybe about their relative, oh, their hearing loss is just mild, it doesn't bother them. But oftentimes people with hearing loss hide how much it bothers them or try to. They don't always let you know that they have a hearing loss or let you know when they're struggling. And there's no such thing really as a mild hearing loss, in the sense that even people with milder levels of hearing loss will struggle in those everyday situations like using the phone or communicating in background noise. So the first step for making your research accessible is to educate yourself about hearing loss and deafness, and there are various courses and awareness sessions and events you can go to. You can also identify suitable collaborators, and I've put some organisations at the end that might be useful as a starting point, but you can also look at your local support groups, local deaf clubs, and local lip reading classes as well. Another important step at the beginning is to see if you have the resources to do this. Do you have funding for a sign language interpreter? And is the loop system working in your department? In terms of methods, there's no right or wrong. It's often about being flexible and giving people options. So if you're running focus groups, you might want to give people the option of a one-to-one session, or maybe having a smaller focus group that's less busy. And people can take part online or in person. It's kind of personal preference, really. And again, it's important for you to take the lead and for you to explicitly let people know you will make accommodations for different communication needs or different sensory losses. Because people do get tired of having to advocate for themselves and they won't always let you know what they need. So you kind of need to raise the topic. This is a list of communication tactics that you should use. Some of them may seem quite basic, but the feedback from people with hearing loss is that often the basics are not done. We're not getting the basics right in research and in clinical practice. And oftentimes people start off with good intentions and then they fall back into bad habits very quickly. So it's important to make the environment as quiet as possible and ensure it's well lit. Always face the person, and it's very easy to get into a bad habit about that, but always make sure you're facing them when you speak to them. There's no point shouting or speaking in an exaggerated manner, like extra slow. That doesn't help them because it changes your lip pattern. It's better to speak clearly and at a normal pace. And it's also a bit patronizing as well. And as I said before, just repeat as often as they need you to. These are some general tips for making your research more accessible. We talked about providing breaks. You might want to make your session shorter so that it's less fatiguing, but you might also make it longer so there's more time for breaks and also more time for recaps. It's very important to summarize the discussion as you go along. So if you're doing a focus group or a meeting, if you've got hearing loss, you might be scared that you don't want to say something in case someone else already said it and you missed it. You might have lost the thread of the conversation. So it's good to have a summary every so often to orient you. And also it's good to give people an agenda in advance and written information about what to expect. And then you should try to stick to that because that is important contextual information for them. These are some more tips about just in general making research accessible. When you're doing an online call, it's good to ensure that the speaker is pinned so that people can lip read them and show people how to use the captions. If they're coming for a face-to-face appointment, you might have a tablet with the speech-to-text app. But even with technology, it can't replace good communication skills. You need both. And as I mentioned, things like tinnitus and hyperacusis and even hearing loss can be distressing and can also cause fatigue. So you have to be equipped to support people with that. In terms of venues, what's fashionable at the moment is things like wooden floors and glass walls and high ceilings, but that's not very friendly for people who have hearing loss. It's not a good environment for sound. So you might want to consider something else. The main thing is to ensure it's well lit and it's quiet. If you do want people to break out into little groups for discussions, you might need separate rooms for that, because if they're all in one room, it's going to get noisy. And it's also good to have a private space. For example, if someone with hyperacusis needs a break, or what we hear from people who have hearing loss is that when they want to discuss something private, people start speaking quite loudly to them so they can hear, and it sort of broadcasts the conversation to everyone. So it's good to have a private breakout room. And if you're having a talk or a conference, in addition to the screen with the slides, you could have a screen with the live transcript or captions displayed. Of course, you can have interpreters as well. So if you are working with people who use sign language, it's important to remember sign language is a different language from English. It's not just like a visual version of English. So don't assume words from English are going to directly translate, or that you can use written English as a substitute for sign language. So what you might want to do is get your documents, like your information sheet, translated into a sign language video. And also book a professional interpreter. Obviously, don't rely on someone's family member. And if you want to discuss private things, you might want to give them a choice of interpreter. Maybe they want someone of the same gender, for example. You also have to think about, if you send out sign language videos to people, how are you going to communicate with them afterwards? If they have questions or want to get in touch with you, you might use a video relay service or have an interpreter or allow them to upload videos. You have to think about the two-way communication. And in trials or ongoing studies, it's important to kind of check in every so often that they're still happy to take part, because the deaf community have had bad experiences in the health service and bad experience with things like taking consent. So that can be reassuring for them. This is just a list of some of the key organizations, like various charities and societies, that would be a good place to learn more information. And they might offer some sign language services as well. I would have a go at these simulations after the talk, simulations of cochlear implants, hearing loss, and tinnitus. They're not perfect, but they give you a good idea. There's also some links here for devices and some reading, including the RCGP Deafness and Hearing Loss Toolkit. And we will make these slides available on the website afterwards, so you can get access to this information there. And also you'll be able to see my references there. So in just a moment, I'm going to hand over to our expert by experience, John, to have a chat about his insights. But before I do, just feel free to get in touch with us at the Nottingham Biomedical Research Centre. We carry out lots of research about hearing, about tinnitus, and about hyperacusis. So feel free to get in touch with us. And you're also very welcome to take part in my survey, which is open to researchers, health professionals, and people with lived experience of hearing loss and their relatives. So all of these links will be available on the slide. So I'm going to stop sharing now and hand over to John.
Thank you, and good afternoon, good morning even, yes. Okay, first of all, I'd like to say a huge thank you to everybody who's turned up today. I know how precious your time is, so I'm very grateful for you lending me a little bit of it. Edna introduced me at the beginning with a list of the various bits and pieces that I do with regard to research. And that's really good, but it says what I do rather than who I am. So I'd like to introduce me a little bit, if you don't mind. For example, I've ridden a yak in Mongolia. For my 60th birthday, I hung off the CN Tower, the tallest building in Canada, on a piece of rope that was about the same size as my little finger. It was my wife's idea. I'm not sure about that. I've washed an elephant in India, and I've danced with the English National Ballet. Yeah, I know it's hard to imagine, but it is true. I have washed an elephant. I've also got hearing loss, but my hearing loss doesn't define me. It is just part of who I am. And that's an important thing to remember. And my hearing loss is very individual, as is everybody else's. To say that somebody has hearing loss, it's like describing something as a car. You know, yes, it's technically accurate, but it's not definitive. You know, is it a Reliant Robin or a Porsche? And they're both cars. So that really is the biggest and most important factor that I can bring to you is, and it's going to sound like a joke, but it's not. If you are talking to somebody who has a challenge with hearing, the most important thing to do is to listen. Ask them what they need from you to help them. And absolutely right, I totally agree with what Etna said earlier. Hearing aids are wonderful, but they do not give you the hearing of a 20-year-old. You know, they do make things very, very much easier, and they have improved and continue to improve. My biggest challenge is live meetings. I am absolutely fine on this. Teams and Zoom, perfect for me. I can sit here. You've all got microphones, and please note that don't use the mic in your laptop or the camera, they're useless. Use a microphone. I've got my earpiece in, whacked up to a level that will probably bring tears to your eyes, but I can hear perfectly. In a live meeting, not so much. So how do I cope? I go into the meeting room first to hear what the echo is like, to hear what the sound is like, how the tables are laid out. If I'm going to a meeting with people that I know, I very carefully select the seat that is going to be closest to the people who don't talk very loudly. Not everybody does. And as Etna said, I can hear some people perfectly, and others who speak at the same volume, I have difficulty with. So that gives me the management of the situation. Big meetings and conferences can be an absolute nightmare. There is so much background noise. Big rooms, especially, to be sort of these ballroom type things. For example, I went to an Academy of Medical Science event in Birmingham a couple of years ago, and we had, I think it was 20 mini meetings held in a ballroom. It was like the Tower of Babel. I could hear absolutely nothing except everything that was going on behind me, which is another wonder of hearing aids. So what the Academy did for me was we had a separate room. So the meetings that I joined, we just got up and went to a quiet room where I could be involved in that meeting. And when that particular meeting was over, we went back and I joined another meeting that moved out, because we talked and they listened to what I had to say before the meeting. And again, going back to something that Etna said earlier, please, please, please do not cancel coffee breaks. Apart from the fact that I need my regular caffeine hit, active listening is incredibly hard and tiring. I need a break, and you will very often find me disappearing with my cup of coffee to a quiet corner where I can stare at the wall and decompress, because it is really hard work. And I need those breaks to actually carry on with the day. So please bear that in mind. And if I ever come to one of your meetings, I'm not being antisocial, honestly. And one quick word about loops. So many places think we've got a loop, we're sorted. Wrong. An awful lot of hearing aids these days don't have hearing aid loop technology in them. They've gone for Bluetooth. Mine connect wonderfully to my phone and my computer, but don't work with a hearing aid loop. So do bear in mind, don't just think because you've got a loop, you solve the problem. And I'd like to come off the piece a little bit, if you don't mind. I can see Etna panicking now. And talk a little bit more generally. I'm preaching to the converted. You're here today. Do you clearly understand the importance of involving people in your research work? Experts by experience are proven to add value. They're proven to add a focus to research. And if properly included, they can improve your funding prospects as well. We all know how difficult it is getting money for anything these days. And an awful lot of the funders now are looking at experts by experience and how you're including them in the work that you do. And you'll notice I use the term expert by experience rather than patient participant. I'm not a patient. I don't consider myself as one. But I am an expert by experience in the things that I experience, type 2 diabetes and hearing loss specifically. So do bear in mind that, you know, we can really make a difference. In fact, it's so important that the Academy of Medical Science last year introduced funding so that you could include patients at the design stage, a gap that they recognized, that you don't get the funding until after you've got the design. So they're filling that gap. So that indicates the importance of experts by experience. And experts by experience can have hearing loss, just like any other expert by experience. And the importance of including people. We're your biggest fans. Bear in mind, the work that you're doing will have an impact on our lives. Whatever work it is that you're doing, you might even be saving my life by the work that you're doing at some point down the road. So we are your biggest fans. And if your work is grounded in the real world, it is far more likely that it's going to have a positive outcome. So please don't just go away, because I know you're converted, but when you're having a coffee and a piece of cake with your colleagues, and whenever you're talking to them, please, please, please tell them that the value of including experts by experience as equal members of your team, so that they can be involved and they can help you to shape the future of your research. That's the end of my sermon. Etna's got my email. If you want to talk to me at greater length after this, by all means, I am happy to do so. Obviously, if you have any questions immediately, pop them in the chat, and I will hand you back to Etna. Thank you very much for listening.
Thank you so much, John. I really appreciate you taking the time to come share your experiences with us. I guess now it's time for questions. If anybody does have a question, feel free to put it in the chat or to let us know. I can see that our colleague Helen has put something in the chat. Yes, so it's telling us about, you can learn more about John. He's been part of a toolkit co-developed in Nottingham to support people to use their hearing aids, and that's with RNID, who are the national charity for hearing loss. So the link for that is in the chat, which is great. Thank you, Helen.
Right, I can't see any questions coming through at the moment, but thank you, Etna, John and Paul, for that. That was fascinating. As someone who does have hearing loss as well, it raised a lot of things in my mind that I'd never even thought of before, because many conversations I have, I start with people saying, oh, I'm deaf in one ear. And so you've raised a lot of points there that I think are very, very interesting and useful.
Thank you. I did think of a couple of other points, which was for people with hyperacusis, sometimes taking part online can be good for them as well, similar to what John was saying in terms of having control of the environment. You know, when they're at home, they can turn down the volume if they want, or, you know, turn it off altogether, or take breaks without having to kind of get up and leave the room. They can just take a break whenever they want. But some people also, even if they have something like hyperacusis or hearing loss, might still like to take part in a face-to-face group session if they kind of want the social element or the opportunity to meet other people who have the same, you know, who also have hyperacusis. So you just have to give them options. And the other thing that came to mind as well is it's definitely very important to consider having BSL interpretation. But not everyone uses BSL. Like people who have hearing loss, many don't use sign language. So just having the interpreter isn't enough for everybody. You need to make other accommodations too. So thank you. I think some questions have come through now.
Yeah, Emma has asked one. On one of the slides had a bullet on phone for texting participants. Can you please explain what you mean by this?
Sure. That's something I found helpful in my research, because a lot of times we rely on either emailing people or telephoning people. And telephoning, as we said, isn't great because you can't lip read. So a video call might be better. But also a lot of people do just like a text message. Not just people who have hearing loss, but I found that with various underserved communities that I've worked with. they actually might just prefer a text message. And especially if you're trying to arrange to meet with them or them to find your building or to find where the meeting is, email's a bit inefficient. So being able to send them a text rather than giving them a quick call. So, I always try to put money in my grant for maybe a mobile phone and a mobile phone contract to be able to contact people off a work mobile phone. So it's just as simple as that, really. But yeah, I find a lot of people want to use text or even WhatsApp as well.
Right. We have another question. Is hyperacusis, apologies for the pronunciation, is it related to autism?
Yeah, there is a relationship. Paul might be able to answer this better than me. I'm not a hyperacusis expert, although some of my colleagues are. There is a relationship between the two. It doesn't mean that everyone who has hyperacusis has autism and vice versa, but certainly there are many people with autism who do have hyperacusis. I don't know if, Paul, you wanted to add anything.
Just very quickly, really. I think that there has been some associations found in research, but I don't think there's a definitive anything that says like hyperacusis is resulting from autism. I think it's one of the signs and symptoms they experience. So I think it's a really good question, but I'm not sure exactly what, without going into the current research, what's currently available now. But we do have actually people, experts at Nottingham, who actually would be able to answer this really, really well. So if we could probably find out a really good answer to that and get back to you if you want. I'm happy to do that.
Yeah, I think at the moment, it's difficult to say. We don't exactly know what causes hyperacusis. We just are aware that there are links. But yes, my colleague, Catherine Fackrell, is one of the main experts we have on hyperacusis. So if I can find, if you want to get in touch with me, I can put you in touch with her, or she will be on the Nottingham Biomedical Research Centre website as well.
Right, thank you. We have another question. Earlier you mentioned that written English is not a substitute and that BSL video should be prepared for documents. Is that for participant sheets as well?
Yeah, I think it's not that some people in the deaf community do read English, but you can't just assume. And also, it's not their first language. So if you're specifically wanting to work with the deaf community, that does take resources. It does take, you might want a colleague like to work with a researcher who's from the deaf community, or certainly have a partnership with an organization that represents the deaf community. And you would have to look into translating information sheets, consent forms, surveys, and thinking about how are you going to communicate with people if you can't just email back and forth. So it might be using a video relay service. So some of the links of the organizations I put in the end can help with that if you look into them. But yeah, and you also have to think about, for example, if for a consent form, what you might do is rather than sending out a document, you might actually just do it as an interview with someone with an interpreter and get their consent that way. So you would have to clear that with the ethics committee that you're going to do the consent in a slightly different way. It's probably similar for other conditions that you have to make adaptations to the form for as well. And if you do translate a survey, you have to think about how are they going to give their responses. If you've got videos for the questions, can they upload a video response? Or do you want to do it as more of an interview style questionnaire rather than a postal or an online survey? So yeah, I would think about all your documents.
Right. And I think Linda makes a good point as well, because I know this myself, is to get someone's attention before you actually start. The number of times people start speaking to you and you don't hear them because you're not expecting them straight away. So yes, Linda was saying the hearing loss slows down the processing, especially if they don't know the context. So I think that's another great point as well.
Yeah, definitely people have said that to me when we were having a meeting the other week and we were having a virtual whiteboard on the screen and everyone was contributing. The discussion was moving a bit too fast for some people. It's just they need a slightly longer time to process. So having breaks and having summaries is very important. I don't know if John wanted to add something as well.
Yeah, just to say that one of the things that I tend to do with people is I tell them I lip read. I don't, but what that does is that they look at me and they talk clearly, and that helps me to actually hear them. So a little white lie, but yeah, absolutely. One of the problems in doctors' surgeries is they have a tendency to talk to you whilst they're looking at their screen, not at you. That is always a problem, and it is getting people to actually look at you so that you can pick up exactly what they're saying.
Yeah, thank you, John.
Yeah. Right, I don't think we have any other questions. So we can, if nobody has any other questions, we can bring this masterclass to an end. And thank you very much, Etna, John and Paul, for your presentation. And thank you very much, Hannah, for your British Sign Language interpretation.
Thank you.
So